A very good evening to everyone. This is Batul, the moderator for today's session from IJCP, and I would like to welcome everyone wholeheartedly at our platform for the better exchange of knowledge that is going to be shared by our renowned stalwart who is present here with us today. Well, sir needs no introduction, but yet it's our great pleasure and honor to introduce him. He is none other than the very renowned cardiologist Dr. Keshavamurthy CB, sir. Sir is MD in General Medicine, DM in Cardiology, DNB in Cardiologist, consultant at Manipal Hospital, Mysore. With such wonderful insights, we are going to talk about the topic for today, which is classification and diagnosis of cardiogenic shock. Moving ahead with the topic's description, cardiogenic shock is a life threatening condition characterized by inadequate tissue perfusion due to the failure of the heart to pump effectively. Understanding the classification and diagnosis of cardiogenic shock is crucial for timely and appropriate management. In this comprehensive webinar, we'll delve into the complexities of this critical condition and we'll be knowing more about the topic with Sir's wonderful insights. So now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. So over to you.
Thank you very much for the very kind introduction, and thank you all for being present here to have exchange thoughts on this important topic of cardiogenic shock, how to classify it, how to evaluate it, what are the diagnostic features, and some little bit about the management aspects also I'll be speaking today. And we'll also discuss a few points which have changed in the last few years regarding the conventional diagnosis of cardiogenic shock and the present modern management and diagnosis of cardiogenic shock. We all know that cardiogenic shock, by definition, cardio means heart, genic means something arising from the heart. So cardiogenic shock is simply shock which is due to a cardiac cause. Sometimes we do not realize the importance of the heart. We think it is just a quietly functioning organ, it is present, but when it fails, it really causes a serious problem and a threat to life. And that is what this cartoon is depicting. And many a time we think it is just a superficial problem, but at the root of that important problem, there is a hemodynamic cause or a hemometabolic cause which has depressed the cardiac function and has resulted in cardiogenic shock. And when the patient has entered a deep spiral of worsening acidosis, worsening hemodynamics, worsening hemometabolics, acidosis, then death will be imminent despite all our measures. So we should we should not look at it too superficially. Try to get to the root of the problem, understand what are all the etiological factors, what are all the correctable factors, and we also should learn to analyze when patient has reached a point of no return. That means at a point where even a good intervention like a mechanical support or whatever advanced techniques we use may not be of much use. So by definition, it is a state of low cardiac output secondary to primary cardiac cause, because there are other types of shock which can be due to sepsis or high output shock or due to excessive blood loss or whatever reason shock can ensue. But a low cardiac output which arises from a primary cardiac cause. Heart cannot pump enough blood to maintain organ perfusion. That is the simplest definition that a cardiologist can give for cardiogenic shock. The heart as a pump is unable to pump enough blood to maintain organ perfusion. And of course, the hemodynamic as well as the hemometabolic consequences we have to realize. These are two important words and the crux of this talk to understand the hemodynamics and hemometabolics. In the conventional definition of shock, in the classification, treatment, understanding of shock, we used to focus on hemodynamics. That means we used to check the pressures, the systemic blood pressure, the mean arterial blood pressure, the systemic vascular resistance. And from this, arrive at a cardiac output and work on that to improve the cardiac power output. But there was less attention, I would say, to the hemometabolic consequences. Of late, in the past 4 to 5 years, we have realized that even though the hemodynamics are corrected, patient who has already entered the downward spiral of hemometabolic consequences of shock is sometimes irretrievable, and we lose a lot of patients in whom we do say a successful intervention restore the hemodynamic balance, but we lose the patient to the hemometabolic consequences. So that is what has changed in the past few years, and we'll briefly discuss what is that and how to address that. So, what is the etiology of cardiogenic shock? Acute myocardial infarction, large anterior wall myocardial infarction with more than 40% myocardial loss is a common cause. It ensues in about 5 to 8% of all heart attacks, and it carries a very high mortality. Conventionally, the mortality used to be 100% when there were no mechanical devices, there was no surgery, there was no primary angioplasty. Mortality used to be 100%. If a patient is in cardiogenic shock, it was sure shot death. But of late, with early recognition and treatment, institution of mechanical support, the various diagnostics, advanced diagnostics that we have, and also the therapies, and the diagnosis has become earlier and earlier, and many of the treatments are preemptive. That is, you recognize a patient who is at risk of developing a cardiogenic shock, especially if there is a semi-elective situation, like you have taken up a patient for an elective or a semi-urgent angioplasty and he requires hemodynamic support. In those situations, you realize that this patient can land in cardiogenic shock and take preemptive measures, institute a mechanical circulatory support, and that is how we save lives. So that is what has saved lives. But still, there is a considerable mortality from this condition. That's why it's always a feared term when somebody utters the word cardiogenic shock. The cardiologist, it still carries a mortality of about 40 to 50%. Though with all the recent advances, the overall mortality has decreased by 50%. It is still about 40 to 50%, even in the best of centers. So, in the etiology, we all know that if there is a mechanical complication of myocardial infarction, like ischemic ventricular septal rupture, or a free wall rupture, or a papillary muscle rupture, or pericardial tamponade, this results in immediate hemodynamic collapse, and thereby a patient lands up in shock. There are some rhythm problems where directly they can push the patient into shock, like ventricular tachycardia, hemodynamically unstable ventricular tachycardia, especially when associated with an underlying myocardial infarction. Of course, ventricular fibrillation is almost always a fatal arrhythmia unless it is treated. It has to be treated with an electrical defibrillation. There is no medical treatment for ventricular fibrillation as such. And extreme bradycardia with very low heart rates, untreated, will result in cardiogenic shock. So, what are the symptoms? How do you recognize? Like I said, it has to be intuitive, and many a times you have to anticipate that this patient might slip into cardiogenic shock. Otherwise, the time window for treatment is lost, and we ultimately lose the patient. So, the symptoms are of low cardiac output. So, what are these symptoms? Extreme fatigue, weakness, sweating, giddiness. Sometimes syncope may be the presenting feature of cardiogenic shock. The secondary symptoms are of organ malperfusion, which include low urine output, which is one of the earliest recognizable signs, loss of appetite, cerebral hyperperfusion, confusion, irritability. So, when we see a patient in the emergency room who is confused, irritable, has low systolic blood pressure, and also has a low urine output, when you catheterize this patient, there is no urine in the urine bag. You're always almost always sure that this patient has landed up with cardiogenic shock and also the organ malperfusion. So, how do you classify cardiogenic shock? What are the different stages of cardiogenic shock? A is at risk. This is the SKY classification. At risk of developing cardiogenic shock. B is the beginning of shock, where you can anticipate and really intervene and take care of these patients. C is where they already have classic symptoms of hemodynamic variations and also the early hemometabolic consequences of organ malperfusion. D is deteriorating, where shock has established for a few hours and patient is already on a downward spiral. May be difficult to retrieve these patients, but some of them definitely, with the right kind of interventions and uh, aggressive interventions or mechanical circulatory support, we can retrieve some of these patients. Of course, extremists or patients who are already in cardiac arrest or on a CPR or on a ventricular assist device or persistent ventricular fibrillation, things like that. Extremists are patients who are on advanced cardiac life support systems. So this is how we classify cardiogenic shock. Basically, A, B, C. A is very good, where we can preemptively intervene. B, still good for intervention, and if you do the right kind of intervention, you can still reduce the mortality by 50%. In classic, You have to choose your patients and intervene. But in deteriorating and extremist patients, we have to be careful about which patients we are going to salvage and at what cost. That we have to realize, balance the risks and benefits, and then go ahead with that. So, at risk patients, who are the patients that we see in day to day practice who are at risk, but they are still not in established shock? An anterior wall myocardial infarction, always a risk factor because a large myocardial territory is involved in a dominant left system. Left anterior descending artery occlusion is many times fatal. Myocarditis, large pericardial effusions, these are all patients who are at risk of developing a shock at any time. Beginning of shock, they have early features like restlessness and fatigue. Some of these symptoms may be subtle, they may not be overt, so that as soon as you see a patient, you may not realize that the patient is in shock. And especially when in the initial stages, there is a compensatory mechanism of the activation of the sympathetic nervous system, which tries to push up the heart rate and also the blood pressure to some extent. So when you see a patient in the emergency room, though the patient is in cardiogenic shock, his systolic blood pressure may be hovering around 90 or even 100 systolic, but there is tachycardia, patient is restless and he is fatigued, and there is some fall in urine output. If you see all these features, patient is already in shock. You should not be misled by the falsely elevated systolic blood pressure alone. So if you use only one criteria like systolic blood pressure, you may be easily misled. You also have to look at the heart rate, patient sensorium, is there any alteration in that, and any signs of organ perfusion. If it has come out, then it goes into a classic stage of shock. Features of low perfusion, hypotension, low urine output, altered mentation, hypoxia. So if you see all these features, there is established classic shock. And in this situation, if you see a patient who has arrived in cardiogenic shock in the emergency room, there is no urine output, there is zero urine output, and the blood pH is less than 7, it's almost imminent 100% mortality. They would say in certain cases, even with all the interventions of the current era, mortality will remain very high in these cases. So you have to be very selective about which patients to counsel for mechanical circulatory support, which patients are intervenable, which patients have a treatable underlying cause. If they have multi-organ dysfunction, very elderly, maybe cancer or secondary to sepsis, where you are not able to retrieve the patient. In those patients, established shock or deteriorating cardiogenic shock, they may not be retrievable. In deteriorating shock, you have worsening acidosis, rising lactates, acute kidney injury. And in extremis, like I mentioned in the earlier slide, the patients are already in a cardiac arrest, loss of rhythm, and patients on CPR, ECMO, or mechanical circulatory support. These are the extreme kind of patients. So, how do you assess these patients? One of the critical things is assessing the cardiac index. Of course, heart is the cause of the shock, so assessing the heart function is crucial to establishing any kind of etiology or getting the patient on the right track of treatment. So, cardiac index is nothing but cardiac output per minute per meter square of body surface area, index to the body surface area. Normal resting index is about 2.6 to 4.2 liters per square meter. It increases 3 to 6 times at peak exercise. That is a cardiac reserve. That is the cardiac index at baseline at rest, and at peak exercise is about 3 to 6 times. That is the amount of cardiac reserve that is present in the heart function. An acute fall in cardiac index leads to cardiogenic shock. In a chronic heart failure situation where there is a progressive loss of cardiac function, cardiac fibrosis, patient may not slip into cardiogenic shock so easily. But if there is an acute fall in cardiac index, like for example in an acute event like an anterior wall myocardial infarction, where there is a sudden loss of 40% of myocardium, it leads to a quickly the patient slips into a cardiogenic shock. So in the clinical evaluation, like we saw in the earlier slides, it is important to examine the patient carefully, look at whether the patient is restless, feels uneasy, sweating, cold, clammy extremities, altered sensorium, hypotension, and elevated JVP. Of course, there are additional features which will help. But like I said, hypotension may always not be the initial presenting feature. The initial blood pressure, the mean arterial pressure, the systolic blood pressure may be normal. So at the outlook, patient looks very stable, but if you carefully see them, they are either restless, sweating, cold, clammy, altered sensorium, tachycardia and tachypnea, acidotic breathing, gallop rhythms. If you can recognize all these subtle features, You can put them all together and make an assessment of cardiogenic shock very early in the stage of cardiogenic shock. Low peripheral O2 saturation, of course, it's a good alerting feature to know that the systemic saturations are low. So this is the most important slide, I would say, in this whole presentation: hemodynamic versus hemometabolic shock. So these terminologies have improved our understanding of why mortality occurs in a patient with cardiogenic shock. So the initial part of shock, there is a hemodynamic change. That is when there is a myocardial infarction or some mechanical complication, there is a fall in systemic blood pressure. So what does it cause? This reduces the organ perfusion. In spite of the organs having their reserve function, the body trying to push up the systemic blood pressure, the body trying to selectively perfuse the vital organs and reduce blood supply to the periphery, all these compensatory corrective mechanisms do take place in the body as soon as the shock sets in. But when all these mechanisms are overwhelmed, shock ensues. And then the hemometabolic consequences start to occur. So early correction of hemodynamics will lead to recovery. Whenever we recognize that a patient is at risk or slipping into cardiogenic shock in the initial phases, if you recognize and correct the hemodynamics in a very able manner, if you can give good hemodynamics, the organs will recover and the whole sequence of events can be reversed. Whereas patient is in cardiogenic shock for a certain period of time, certain period of unknown time. Many a times you don't realize how long the patient has had chest pain and he is in shock, how long his blood pressure has been low, how long he has not passed urine. It's not clearly definable in many situations. In those situations, already patient has he has established hemodynamic problem plus also a hemometabolic problem, which doesn't present itself outside. You recognize the hemodynamics easily, but the hemometabolic consequences need further a deeper point of assessment. So when these prolonged adverse hemodynamics are there, the patient at one point he reaches a point of no return. That is that downward spiral of severe acidosis, worsening acidosis, low organ perfusion, worsening multi-organ dysfunction, which will ultimately lead to cardiac arrest and death. So assessment and intervention at the correct stage is recovery. It makes all the difference for the patient. And if we miss that stage, if the timing of intervention is delayed, this leads to sudden death. Like I would like to give an example. When patient arrives with an acute myocardial infarction of unknown duration, many a times, especially in our Indian scenario, they are not able to correctly time their infarct. They would have had some, most of the times it is treated as a gastritis or they take some injections and tablets. And when there is a hemodynamic problem or an arrhythmia or some kind of a syncope or a collapse, then the patient arrives in the emergency room. You do not know how much time has elapsed in which the patient has been in hemodynamic shock. So we pick up these patients, quickly do primary PTCA and revascularize these patients because from our side it's an urgent thing, and if we revascularize, we hope that the myocardium will recover and start functioning. Many of the times we do successful angioplasties, revascularize these patients, and we are quite happy with the result, very good result. We have done a complex procedure and then we go home, and after about 4 or 6 hours into the night, patient suddenly has a cardiac arrest. So we do not quite understand whether something went wrong with the procedure, patient had a stent thrombosis or things like that, but that's not true. Patient has had a hemometabolic irreversible cardiogenic shock. He slips and then he finally succumbs. There is a mortality. So that is why the understanding of hemometabolic shock is very important. Just by giving a few inotropes and pushing up the blood pressure, will not be able to correct or reverse the hemodynamic consequences. So if we have understood that part, our management of shock becomes totally different. Our assessment, our prognostication, our counseling of the patient attendants becomes totally different. So in the biochemistry, like once we have finished the clinical assessment, we are always dependent on the biochemistry. There is severe acidosis. If the serial lactates are rising instead of falling or being at the same level, we are sure that this patient has already entered a downward spiral. Altered renal and hepatic parameters and non-invasive echo calculated stroke volumes are an important indicator of how our cardiac output scenario is going along, and whether it will improve the organ perfusion or it will worsen and cause further fall in the organ functions. So Biochemical assessment, simple things like acidosis, three or four tests, the kidney parameters, liver parameters, rising lactate levels, acidosis, and evaluation of stroke volumes. So there are certain criteria for assessment. The set criteria: systolic BP less than 90 for more than 30 minutes, inotrope requirement to maintain systolic BP above 90, one or two inotropes or escalating inotropes is a sign that patient is slipping into cardiogenic shock. Mean arterial pressure less than 60 to 70, capillary wedge pressure more than 15. Most of the situations we can put a wedge catheter. Right heart catheterization was the standard several years, about 2 decades before it went off for a period of time because the complications were more than the benefits derived from the hemodynamic assessments. But wedge pressure measurement is an important part of any cardiac procedure. So the so-called earlier generation of cardiologists, we still do some kind of assessment to have an indirect assessment of wedge pressure, and sometimes the left ventricular end diastolic pressure itself is an indicator that this patient might slip into or develop a complication during a procedure or land up in acute pulmonary edema. Once you start the procedure, inject some contrast, some of these patients suddenly go into pulmonary edema. You do not understand why this is happening. But if you have done a wedge pressure, measured the pulmonary artery pressures, and have an idea of the wedge pressure, then you will really understand why the hemodynamics deteriorated so suddenly. Even without the first balloon inflation, patient would have gone into pulmonary edema. So if urine output is less than 30 ml per hour, cool extremities, you can calculate the cardiac output and get a true idea of how bad the cardiogenic shock is. So now we'll shift to a little bit of management, though I would not deeply go because it's a very huge topic, management of cardiogenic shock. Addressing the etiology is most important. Here I would like to say one thing. The emphasis in the past decade or two has been on primary revascularization of myocardial infarctions. Now, for the past 2 to 3 years, there is a concept whereby you give hemodynamic support first. That is, when a patient arrives in the emergency room with an anterior MI and is in cardiogenic shock, the cardiologist is always in a dilemma whether to spend a few minutes extra and put an ECMO or establish some kind of mechanical support with some device, or do a primary angioplasty, revascularize the patient first. So this is always a dilemma. But of late, there are few studies which have showed that patients whose ventricles have been unloaded by putting either an impeller device or an ECMO or some kind of mechanical support, even an intra-aortic balloon pump primarily for that matter, though there are many studies which have shown that intra-aortic balloon pump is not so useful clinically, practically at the bedside. The most widely available device that we have for mechanical support is the intra-aortic balloon pump. So there are several centers who do this. That is, when a patient comes with a myocardial infarction, unload the ventricle first, even before the revascularization, which is totally against what we were talking of all this past decade. So they unload the ventricle, then take the patient to the cath lab, do a angioplasty comfortably. So even that 20-30 minutes which is lost in instituting an ECMO or a impeller device is made up by the revascularization later, because of the benefits of unloading the ventricle are more. Because ischemia, persistent ischemia, a loaded ventricle, that means a ventricle which is not able to pump, it quickly slips into shock. So the outcomes are better with upfront hemodynamic support in these patients. Acute MI, primary angioplasty, prompt revascularization, surgical correction of mechanical problems. For mechanical problems like papillary muscle rupture or mitral regurgitation or septal rupture or even a free wall rupture for that matter, there is no medical solution. These patients have to be treated with emergency surgery, of course, with ECMO or some kind of proper mechanical support. If there are persistent arrhythmias, restoration of sinus rhythm by electrical cardioversion or pharmacological cardioversion is a must to ensure that hemodynamics get better. So prompt treatment reduces mortality by 50%, like we discussed in the earlier slides. So pharmacology, most of the people are familiar. The initial volume challenge with a good volume, because many of these patients may be volume depleted. They might have received a diuretic or they are dehydrated, not consumed anything for the past few hours before you see them. Inotropic support, the preferred agents are norepinephrine, epinephrine, milrinone, as opposed to the dopamine, dobutamine era. Now we are into the norepinephrine era. Correction of acidosis, very important, extremely important point in the treatment of shock is correction of acidosis. Many times we ignore it and suffer the consequences of that. One of the most difficult And crucial things is correction of acidosis. Even with preemptive dialysis, trying to bring that pH to the normal. Many times we ignore this. We say, okay, lactates are 6 or 8 or 10. We will give intravenous soda bicarb and that will correct the things and try to improve the hemodynamics. But it is the acidosis which kills the patient in many of the situations. Mechanical circulatory support is another big topic, but I'll briefly mention that. Intra-aortic balloon pump, which is short term, you can keep it for about 48 to 72 hours. If there is no limb ischemia, for a slightly longer duration, but not much longer than that. And the hemodynamic support provided by an intra-aortic balloon pump is lesser than all the other devices. About 1 to 1.5 liters of cardiac output may be produced by placing a proper 50 cc intra-aortic balloon pump in an adult. Impella is again a short-term device, but extremely popular in the West, but a very high cost, about 20 to 24 lakhs for an Impella device. It's again short-term, about 7 to 14 days. The Impella can be kept, especially if you put an axillary approach. But there are several access-related complications, bleeding, hemolysis. All these problems you have to be familiar with that and take care of that. ECMO is one sustainable kind of device which you can use for intermediate term and as a bridge to either surgery or transplant or to a ventricular assist device. Extremely useful in cardiogenic shock. Uh, Centrally placed ECMO can be done, or a peripheral ECMO. The VA kind of ECMOs can be done to support the hemodynamically unstable patients. So we have left ventricular and right ventricular assist devices which can be used as bridge, or they themselves be the destination in selected patients. So this is an impeller device where you keep the catheter in the left ventricle through a femoral or axillary or subclavian access. There is a pump here which picks up the blood just like a submersible borewell pump, picks up the blood and pumps it out into the aorta. So it gives a good cardiac output. You have Impella CP, it can give up to 5 liters of cardiac output, and you can do any procedure comfortably, even with a patient having a ventricular fibrillation or a complete cardiac standstill. An Impella will continue to support you for up to 7 days. In most of the procedures which use Impella, they once the procedure is done within 24 or 48 hours, they remove the Impella device and take care of the access site. Extremely useful device, but extremely expensive. So ECMO, we are all familiar with veno-venous and veno-arterial ECMO. For cardiogenic shock, we require a veno-arterial ECMO. We draw blood from the circulation and return it back with a pump and an oxygenation and a temperature control. It's a fairly simple mechanism, but it is associated with its own complications related to access, related to thrombosis, related to incidence of strokes. So we have to anticoagulate the patient and take care of the patient really well round the clock when you put them on ECMO. So we also have now a variety of devices which are now available: left ventricular assist device, right ventricular assist device, total artificial heart. So there are several advanced options, including transplantation. You put the patient on a support device and then bridge him to a transplant till the heart becomes available. So in summary, cardiogenic shock is an extremely mortal condition with excess of mortality of about 90% if untreated and unrecognized. And early recognition, as I have stressed throughout the talk, it's very, very vital. But now treatment options are available, though they are expensive. With increased use and availability, the costs are likely to come down. And anticipation and prevention is extremely important. Thank you all for your attention, and I hope you had a few good learning points from this session. Thank you for the opportunity to be with you all.
Thank you so much, sir. Thank you for your overwhelming talk that you have shared on our platform and for sharing these wonderful insights with us. We have received few questions from the participants. So, with all your due permission, I would like to put across those questions to you.
Sure.
Yeah, and the first question is, what are the primary hemodynamic criteria used to classify cardiogenic shock and how do they correlate with patient outcomes?
Right. Basically, in the hemodynamics, we use the systolic blood pressure, though it has its own fallacies. Systolic blood pressure less than 90, or a mean arterial blood pressure less than 60 to 70. And this is on the systemic side. If there is any evidence of increased systemic vascular resistance, and when you calculate the cardiac output, if the cardiac index is low, these patients can be classified as hemodynamic shock. So usually the wedge pressure, the left ventricular end diastolic pressures are all high because it is a cardiogenic shock. The heart is not pumping, and the cardiac output is low. The systemic blood pressure and the mean arterial pressures are low.
Thank you so much, sir. Thank you for answering that question. Moving ahead with another question that we have received, and the question is related to the how does the presence of multi-organ dysfunction impact the classification and prognosis of cardiogenic shock?
Very significantly, I would say, like I mentioned in the talk, if there is onset of multi-organ dysfunction, if two or more organs have been affected, like the kidney, liver, and heart, of course, the cardiogenic shock itself by definition involves the heart, the mortality increases tremendously. Mortality is in excess of 50% if patient has dysfunction of two or more organ systems.
Thank you so much, sir. Thank you for answering that question. Moving ahead with another question that we have received, and the question is: suppose if a patient is having hypertension history, and along with that, the patient is also diagnosed with CKD, and after undergoing dialysis, the patient has several BP fluctuations. Then, in that case, what to do?
It's an extremely common situation in hypertensive and dialyzed patients for systolic blood pressure to fluctuate. This is due to various reasons. Many of the patients have dialysis disequilibrium, whereby at the onset of dialysis, when a certain amount of blood is taken out into the dialysis circuit, there is a fall in systolic blood pressure. Many of the patients with normal left ventricular function and who are non-hypertensive and otherwise are relatively well preserved tend to take this with the adjustment in the body's hemodynamics, and they quite easily adapt to that. But the hypertensives, especially those who are on multiple medications, tend to develop hypotension at the onset of dialysis. So these patients, we tell them to omit their dose of drugs when they come for dialysis and take it after the dialysis. Once the blood pressure dialysis has been completed, about 4 to 6 hours later, they can take the usual dosage of drugs.
Thank you so much, sir. Thank you for answering that question. Moving ahead with another question that we have received, and the question is: what is the importance of early identification of cardiogenic shock in an emergency department, and what are the best practices for achieving this?
Absolutely important and very critical question. We have to recognize that the patient has arrived in cardiogenic shock and try to determine, if possible, how long the patient has been in cardiogenic shock. Because if the, like I mentioned in the talk, if the patient has been in shock, the time the patient has a hemodynamic imbalance, the time spent in poor hemodynamics determines the outcomes. So if you can establish that the patient is already in hemometabolic shock at arrival itself, then you can counsel for a very high mortality, because whatever measures you institute, mechanical circulatory support or ECMO or VADS, the outcome is likely to be poor. Like I said, a very quick assessment of the patient's hemodynamics, the systolic blood pressure. Of course, in the emergency room itself, you can clinically see whether the patient is restless or hypoxic. Just do a blood gas, determine the blood pH and the lactate. Simple measures. Put a urinary catheter and see the urine output. Like I said, if the pH is below 7, anything below 7, and there's no urine output, this patient will have very high mortality in spite of all therapies. So it's extremely crucial from the point of what type of treatment and how aggressive course you will take to salvage this patient. And also it will help you to counsel the patient attendants upfront, so that, because sometimes the patient come into the emergency room walking, not in many instances, but some of the shock patients can come on a wheelchair or in an ambulance. Patient attendants feel the patient is quite okay because he's talking, a little restless, little sweaty, but the hemometabolic consequences nobody realizes. So if you assess it upfront, give the proper picture, if you are able to give a reasonable picture, and the high mortality, despite the various measures that you institute, many of which may be expensive. Like, for example, if a patient has come to a emergency room, you think he is a young patient, let us salvage him and put a impeller device. Impeller, suddenly you put something which is costing about 20 to 25 lakhs in the emergency room. And despite adequate counseling, sometimes if the mortality results, you will face a very adverse situation. So you have to carefully evaluate, take a few minutes, to get a good picture of in what stage the patient, uh, what stage of shock patient is in, and give an appropriate outcome related prognosis to that, and then you will be relatively safe.
Thank you so much, sir. Thank you for answering that question. Last question before we conclude, and the question is related to the use of invasive hemodynamic monitoring. So, how does the use of hemodynamic monitoring, such as pulmonary artery catheter, contribute to the diagnosis and management of cardiogenic shock?
Absolutely. A simple thing like a pulmonary artery catheter can give you very crucial information. You can calculate the cardiac output, which will give you the cardiac index, which right away clears any doubts about the diagnosis of cardiogenic shock. If the cardiac index is normal, it becomes a non-cardiogenic shock. Then you can look at other causes, sepsis or high output cardiac failure or blood loss or whatever. But if cardiac index is low, then it is cardiogenic shock. So you can define the diagnosis, and the second thing you can measure is the capillary wedge pressure and how responsive it is to your measures like inotropes or fluids, which you can challenge that and continuously monitor the hemodynamics during your therapies. So if patient is responsive in the early period, suppose you give a single inotrope, blood pressure becomes normal, you give a diuretic, wedge pressure becomes normal, patient starts passing urine, lactates and the pH improve, then you're sure you are going the right direction and you can continue those measures and salvage this patient relatively easily. As opposed to a patient whom you put a pulmonary artery catheter, the wedge pressures are going up, the pulmonary artery pressures are going up, the systemic vascular resistance is going up, cardiac index is falling, urine output is falling, patient is having worsening acidosis. So this patient is likely to head north and he is unlikely to recover. So it is extremely useful where you selectively choose those patients, measure the hemodynamics, and act accordingly.
Thank you so much, sir. Thank you for answering that question and all the other questions, and for making our viewers understand about the topic in such a better manner, and for answering the questions. I would also like to thank all of our viewers for their ardent participation that they have shown by staying tuned with us throughout the session. Thank you so much, sir. Thank you for your valuable time. And with this, we would like to conclude the session here for today. Until next time.
Thank you all. We'll meet again in the next edition of the class.
Thank you, sir.